We'll go ahead and get started. So I'm just going to introduce Dr. Brian Feeley. Dr. Brian Feeley is an orthopedic surgeon who specializes in using arthroscopic procedures to care for patients with athletic injuries of the shoulder or knee. After earning a bachelor's degree in biology and his medical degree at Stanford, Dr. Feeley completed a residency in orthopedic surgery at the Ronald Reagan UCLA Medical Center. He then completed a fellowship in sports medicine and shoulder surgery at the Hospital for Special Surgery in New York. He's been at UCSF since 2008. Dr. Feeley is section chief of the UCSF Division of Sports Medicine and Shoulder Surgery. He is associate director for UCSF's residency program in ortho surgery. In addition to Dr. Feeley's clinical practice, he runs the Feeley Laboratory for Muscle Regeneration. He was appointed the Ron Conway Family Endowed Professorship in Sports Medicine Research. He has published more than 230 peer-reviewed articles, review studies, and book chapters, as well as a book on rotator cuff injuries. He has served on the Scientific Advisory Board for the National Football League and serves on several national orthopedic research and leadership committees and has received many prestigious research awards. He is also a team physician for St. Ignatius High School here in San Francisco. He is an avid sports fan and hosts a podcast with his fellow surgeons, Dr. Drew Lansdowne and Dr. Nirav Pandya, about sports medicine called 6 to 8 Weeks, which you can find on any of your favorite podcast platforms. Please welcome Dr. Feeley.
Okay. All right. I'll also be available to debunk all the things Anthony said afterwards about PRP. So I was given this title, and I haven't given this talk before, so this may go well, may not go well. How many of you have had patients come in and say, I'm sorry, I went to Google or I went to ChatGPT and had it interpret imaging or labs? Okay, so if they haven't told you, I think they are. So these are my disclosures. The most important disclosure for this is that all images that I used for this were used making ChatGPT, which was actually a lot of fun. And I tried to spend as much time as possible on ChatGPT, and I even spent the $20 a month, so I get the advanced version now, which isn't that much different, except for I'm $20 poorer. Okay, so I started out with needing some help with interpreting a shoulder MRI. So I typed this in, and because I hadn't done this before, and I'm not a patient for shoulder, and I wanted to see what I would get. What I got was ChatGPT's response, which I thought was pretty good. I can help interpret shoulder MRIs based on common findings, but I'm not a radiologist. Great, acknowledgement, neither am I. I can describe the MRI. If you describe the images or the radiology report, I can provide insights on the structures involved, et cetera. It was great. So the problem is patients don't know what's actually clinically relevant. So I use this as an example, and I went pretty far down the rabbit hole. So I said, okay, well, my MRI says I have advanced arthritis in the AC joint. Okay, so it says advanced arthritis in the AC joint means that the joint in their collarbone kind of gives me this whole thing, which is really nice. It's very well laid out that I may have AC joint arthritis. And it says, are you experiencing specific pain or functional limitations? I don't know, maybe. Okay, great. So it's going to give me some treatment options, which sounds exactly like what the Cleveland Clinic puts on their website, because this was pulled directly from the Cleveland Clinic. Would you like to discuss specific exercises or treatments? Great. So now I'm Coleman O'Leary. I can do my physical therapy. It shows me which exercises I can do, which is not that bad. None of them I don't think are wrong per se, as long as AC joint arthritis is my primary diagnosis. Okay, so I've been doing some of my exercises, but oh shit, it gives me, other things. Well, it can also do PRP. Can it show me a study that's effective? Certainly. It searched 4 sites. Thank goodness it searched 4 sites. Because what does it bring me to in these where evidence works for AC joint arthritis? I'm sorry, it brings me to the Panacea Journal of Medical Sciences. This is 1,000 steps below the Lancet. It was a comparative study. I can't point to anything, so I'll point to Dr. Davies instead. But so this journal is so nice. You can actually talk to their bot and get a little bit more information about these studies, which is great. So I signed up Drew Lansdowne to get some extra information. So I'm sorry, Drew. The problem with ChatGPT is it's great for initial information. It gets better and better, but the reality is it does not have the ability to search Google Scholar. It does not have the ability to search PubMed. Anything that's indexed behind a firewall, it's not going to get. So is it going to get Nature? No. Is it going to get the New England Journal? No. So it tends to get open access journals and Frontiers, which is a pay-to-play journal. So the information, at least initially, is not bad, but it's very, very easy to go down the wrong rabbit hole, which I did. So come out of the rabbit hole. A little bit about MRIs, just because I think it's an interesting technology. So it was invented more than 50 years ago now by this guy. And what he found was by putting people in this giant magnet, he could distinguish normal versus diseased tissue. And that in and of itself was fascinating, because at that point we didn't have that ability with imaging. But he actually didn't get the Nobel Prize because nobody liked him, which is kind of sad. The Nobel Prize went to these two people who are responsible for taking that MRI data and interpreting into the 2D image that you see now. So in a true political gesture, he did not get it, but these two nice computer scientists got it for the ability to interpret the MRI. And I think that's important when you talk to patients. An MRI is not a picture. An MRI is a mathematical representation of where water molecules most likely are in your body at that given point in time. So it looks like a picture to us. It acts like a picture, and we certainly treat it like a picture, but it's not actually a picture. It is still a computer representation of where water molecules are. And I think that helps demystify some of the reasons why it's not a perfect picture, and it doesn't always explain symptoms. Now, part of the problem is we use MRI in press. So if you have somebody who plays sports, the first thing they get is they get an MRI, or at least that's what it sounds like. What they haven't said is in the stadium, there's an X-ray machine. So if Jordan Mason has a severe AC joint sprain, he has a type 5 AC sprain, he probably doesn't get the MRI. But what they don't report in the NFL or on The Athletic is Jordan Mason had a negative X-ray and his exam was a little bit confusing. So therefore they proceeded to an MRI. And the reality is that because Jordan Mason gets paid an awful lot of money to go play football next week, it is the financial responsibility for the team and Jordan and his agent to get the MRI relatively quickly to rule out other injuries, because that's what he gets paid for. For your average patient that does computer programming or is a data science engineer, if they have a mild knee pain, they're not getting paid to do that. So it's a little bit of an apples and oranges, even though what patients want is the exact same treatment. If I would access my computer programmer's computer at the same at the same level. If he's got a problem with his Apple MacBook Pro, I want him to bring it to the Genius Bar right away. But do I need to bring his knee there? Not necessarily. Okay, so the keys, I think, to understanding that MRI report is to remember what is normal findings for the age of your patient. And this is really, really important, because your radiologist is blind to this in terms of what they actually report, at least for most. There are some places that have started, especially for spine, saying you have some disc desiccation, normal for age. We don't really do that in the shoulder. Remember the exam of the patient. So it's really important to correlate what you found on the patient with what the symptoms were. And remember, and this is my favorite thing to tell patients when they're like, I really want an MRI for a look-see. I say, great, I'm looking to operate on you. I get an MRI to look for a structural deficiency that I can fix with surgery, or I'm ruling the need for surgery in or out. If you are not a surgical candidate, never want surgery, there's not really a reason to get a look-see of your shoulder. Okay. So let's talk about some of the things that you're going to see on your MRI report and how common they are. So for slap tears, we tend to get this a lot, that slap tears are found. Patients can be induced to have a slap tear in clinic, or at least the symptoms of them, but they're exceedingly common. So when we look at the image-based prevalence of slap tears, if you are 36 to 50 years old, more than half of the MRI findings are going to say that there's a superior labral tear. These are for shoulders that do not have symptoms of a slap tear. When you get up to 65 years of age, more than 75%, in fact, more than 80% are going to have a superior labral tear. So doing an O'Brien's test, evaluating for a superior labral tear is not going to be helpful. But patients, I mean, it sounds really bad, like severe degenerative changes in the superior labrum. If they go onto ChatGPT on that, it's going to say you have a slap tear and you may need surgery for that, which may be a slap repair. The reality is everybody has this. Okay, same with rotator cuff tears. So rotator cuff tears are exceedingly common as we get older. So this was one of my favorite studies ever. Dr. Yamamoto went to a village in Japan and MR'd everybody in the village, which is kind of awesome. You kind of want to do that in Burlingame, really, to scare up the rich people there. But so you had 1,366 patients, 20%, all comers, had some sort of partial or full thickness rotator cuff tear. And over half of them had a partial or full thickness rotator cuff tear over the age of 60. So it's exceedingly common, especially the partial thickness tears. Now, for a patient, they don't know the difference between a partial tear or a full tear. A partial tear to them largely say, if you ask them, can you draw this or what do you think this means? They think a partial tear means there's a hole in the rotator cuff. A full thickness tear means their shoulder is hanging on literally by a thread. How is their arm still on? It doesn't mean that there's a pinhole-sized defect in their rotator cuff. The rest of it's totally fine. So having that ability to explain and interpret that to patients is really important. A partial thickness tear is largely normal for age, especially as we get older, and you are probably not going to need surgery. But the hard thing is for a patient, that is not how they're interpreting the word partial thickness tear. When Yamamoto looked again at his patients, he looked at the patients and actually asked a subset how many of them were symptomatic. 65 of the patients with partial or full thickness tears had no symptoms. They were totally fine. This was a rural village where they were high manual laborers, or high demand manual laborers. So this isn't your computer programmers or your sedentary people. These are people who are actively using their shoulder. And then Moose Meyer, if you don't believe Japanese data and you're like, what do the Norwegians think about this? So Moose Meyer's in the Norwegian countries, and he looked at this and asymptomatic full thickness tears. He looked at them over a period of time in preparation for doing a randomized controlled trial of PT, no surgery versus surgery. 36% of them developed pain within 3 years. So with only a third of the patients with asymptomatic full thickness tears actually became symptomatic. So what I tell my patients when they say, I've got a really small tear, but it's really not bothering me right now because it took 4 weeks to get in. Great. If it becomes symptomatic, come back and see me, but you don't necessarily need to see me back. Okay, so AC joints. Everybody over the age of 40 has AC joint arthritis on x-ray. It probably shouldn't be called arthritis. Arthritis, we get the sense of it's like my knee wearing out, it's like my shoulder wearing out. As soon as you put the word arthritis into a report, it is scary, okay? So the AC joint degenerates because it has a disc in it. It wears out in all of us. So depending on the study you read, 41 out of 50 had AC joint arthritis in New York with Bill Levine and Beth Schubenstein. Relationship between MRI and clinical findings in the AC joint, no real correlation between the MRI appearance and the clinical findings of their AC joint. The problem is this is also often because radiologists are systematic. That's exactly what we want them to do. This is often number one on their report. And the summary is advanced AC joint arthritis causing impingement on the rotator cuff. That sounds like it's a double whammy. It's not. Okay, so I'm going to go through cases, but admittedly, I don't know how to use the app. It's scary and new technology scares and confuses me, so I couldn't figure it out. So I may just have you guys yell things out, and if nobody yells things out, I'm just going to call on Coleman because he's large and sits in the front and keeps flexing. So there's a 51-year-old female, 4 months of shoulder pain, pain at night and with overhead activity. She can't play tennis due to pain, tragic. She doesn't have an injury that she reports, but her husband says she tripped and fell playing tennis. She notes some loss of motion. Pain's kind of all over the place. And she's taken some NSAIDs. PT hasn't helped. Range of motion is pretty symmetric. She kind of gets up to 130, abductor 130, good external rotation. Nears, Hawkins, O'Brien's is all the same. So this is her MRI report. So partial tendinosis without tear of the superior fibers of the subscapularis, without medial subluxation of the biceps tendon. Okay, that's a lot. Moderate grade bursal-sided tear of the anterior fibers of supraspinatus, superior and anterior superior labral tear, edema within the inferior glenohumeral ligament with effacement of the rotator interval fat. Findings can be seen in the setting of adhesive capsulitis. Prominent right axillary lymph nodes, which are nonspecific, correlate with a history of recent illness or injection. All right, so she's going to die of lymphoma. Okay. What's her diagnosis? Right. Well, how come you say that here, but that's not what the patient reads? Okay. So that's awesome. Like I put in, make a picture of me on ChatGPT, and that's apparently what I look like to the computer. So awesome. Also, the shoulder MRI is in the brain. Not so awesome. Okay, so when a patient reads this, though, like it's subtle, but they miss the word without. So partial tenderness without tear of the super fibers of the subscapularis, without medial subluxation. They could say no subscap tear. They don't say that, though. So moderate grade bursal-sided tear of the anterior fibers of the supraspinatus on a background of tendinosis. So what I tell patients for this is a bursal-sided tear, it may cause a little bit of symptoms, but it's also probably normal for age at your age level. And at the anterior fibers, meaning if you have 6 centimeters of a rotator cuff, less than a centimeter is actually partially torn. So in a perfect world, we would have a way to say, this is the volume of your cuff, and then this is the amount that's torn. We don't really have that, but then I could say less than 3% is torn. That would be like me saying, I have 96% of my hair, and I'm pretty okay with that. And then they look at me and like, really? Because your picture out in the front, you had 97, and I looked a lot better. I'm like, no, it is what it is. Okay, superior and anterior superior labral tear. Again, anything that's torn, the word torn gets pulled out for patients in their brain because it sounds scary. She's 51, she has a positive O'Brien's. Really not all that important. But then they give you the diagnosis. They say edema within the IGHL. Findings can be seen in the setting of adhesive capsulitis. Nobody else gets the findings of adhesive capsulitis except for patients with frozen shoulder. So they do give you the diagnosis. They bury the lead. It's way, way, way down there. But if you think about the patient, okay, she tripped playing tennis. People often trip playing tennis or pickleball now. She's globally lost range of motion and everything hurts. That's a classic frozen shoulder patient. And if you look at her x-rays are normal. She has this small partial thickness tear, a point on here because nobody can see it. But basically she has a small bursal-sided tear. The weird thing about people with partial rotator cuff tears and even very, very small full-thickness tears in the setting of frozen shoulder is these are the only patients that actually heal their tear on their own because they have such a robust inflammatory response. I had this patient, in fact, I got a repeat MRI because she was like, I'm better, my frozen shoulder's better, let's fix that cuff. And we got an MRI, the cuff looks fine now. So in some weird paradox, the people with frozen shoulder and a small cuff tear can actually be that small percentage of patients that they heal their cuff. And she's still like, well, should we look at it? I'm like, you're fine. You have no symptoms. Let's leave you alone and see how you do. And it's been 6 months and either she got a PRP injection or she's fine. Okay. Second case, 65-year-old male. He's a firefighter and still does jujitsu, dangerous. He has 3 months of pain at night and pain with overhead activity. He feels a little bit weaker, but not like when we fixed the other shoulder. The other shoulder is like, I fell down, you fixed my cuff, I felt much better. Doesn't have any trauma, doesn't have any loss of motion. He has full range of motion. He's got a positive painful arc, 4 out of 5 in the supraspinatus, and he's a pretty strong guy. 5 out of 5 subscap, positive Nears and positive Hawkins. So he's from way north. He literally does jujitsu all the time, which is dangerous after a certain age, like 12. So when you're 65, I'm a little bit more worried about him. And then this is his MRI report. So massive cuff tear involving the supraspinatus and infraspinatus tendons with differential retraction to the midhumeral head and glenohumeral joint on the background of moderate tendinosis, mild fatty infiltration, and severe AC joint, mild glenohumeral joint arthritis. arthritis. Okay, so to go through this, so first of all, one of the worst things we've done in orthopedic surgery, we've done a lot of bad things, but one of the things that we did bad is we called anything massive. Like, you don't hear cancer doctors describe your cancer as massive, right? Like, that would be horrible. Like, you have grade 1 massive lipoma. Like, that's disgusting. But we grade our tears small, medium, large, and massive. That doesn't mean that those are necessarily going to be harder for us to fix. Okay, that means the width of it from front to back. Okay, and that was based on Dr. Cofield, who was in Mayo. It was a paper in the well-published Obstetrics, Urology, and Gynecology journal back in the early 80s, when he correlated the width of the tear size to the likelihood of success. So the measurement is important, but in terms of how hard it is to fix is the amount of retraction, which they also give us. So when I go through this with a patient, this lines up entirely with his exam. He does have a big cuff tear. It's probably not massive. I think they throw this out. This really was like a 2.5 centimeter tear, but it does start in the supraspinatus and go into the infraspinatus. But all these things are more or less clinically relevant. He has a cuff tear. Sorry, I forgot that part. Again, I'm pretty good looking though. So first thing, massive rotator cuff tear with mild glenohumeral joint arthritis. So that is important. It's something that you have to individually discuss with the patient. We're fortunate in that we get x-rays pretty much on everybody. So I can tell him, you have a little bit of arthritis. It looks a little bit worse than the other side when we fixed it. There are some places where you've lost enough cartilage that I can't see it on x-ray, but I can see it on MRI. So when I go through this with a patient, so massive tear means 5 centimeters, and that is predictive of outcome. So the wider the tear, the less likely it is to heal. Now, when I talked to this patient about this, I did say, really, I would say this is probably a 2.5 to 3 centimeter tear. So I think it's a little bit of an overcall. The amount of retraction is also predictive of outcomes, and importantly, it tells me how I'm going to fix the tear. So when I look at it, if I see a narrow tear that's really retracted, I can kind of zip it together like a zipper. If it's very, very, very far retracted across all the cuts, I may not be able to fix it. I need to start thinking about other things. So that part's important. The amount and quality of the muscle is also really important. So the thing that powers your arm like this is your infraspinatus. The worse the muscle quality and like that, the less likely you're going to do well, even if I can fix it. So if I'm, gifted young surgeon like Dr. Davies, I'm going to bring in all my fancy new techniques. I'm going to put multiple rows of anchors. I'm going to tie it down. I'm going to put a bioinductive scaffold on it. I'm going to put him in the new sling that says Davies across the front. But if he's got fatty infiltration, even if he heals, he's not going to have the strength to power that back. So that degree of fatty infiltration is a predictor of poor outcomes, especially in the infraspinatus. So that's the part that I'm really worried about. Now, the other thing, also a study from Dr. Davies, is that when we see even mild arthritis in the shoulder, they may not do as well with a cuff tear. So that is a patient that if I hadn't gotten an x-ray, I'm going to go get an x-ray, because an x-ray is going to help me differentiate how much arthritis, and I'm going to probably look at exactly, or at least have a conversation with the patient on, hey, you've got some arthritis. The outcomes might not be as good for you as if you didn't have arthritis. Okay, so there, if you want to get really nerdy, there's a Rohe score. So this is, you can calculate this online, and then there's a modified one coming out, but it basically looks at the amount of retraction, how much fat there is, how old your patient is, the level of work, but high demand in this paper is like real high demand. It is not, I play tennis for an hour. It's like I swing a pickaxe for 8 hours. So nobody in America is high demand in this paper. Okay. And then they look at AP tear size. So how much it's retracted. It's very easy because a lot of this is yes or no. And then they give you a chance of healing of good, fair, and poor. So for my patients, when I go through this with them, if they have a good chance of healing, it's a no-brainer. We're going to fix it. If it's fair, I have a pretty long discussion with them, like, here are the advantages and disadvantages. You know what often works is physical therapy. Let's just get you to strengthen your cuff and feel better, or strengthen the muscles around your cuff and see how you do, because many of you aren't going to like the outcome of me doing a surgery that doesn't work. And if it's poor, I don't have a discussion about rotator cuff repair. I do. I say, I can do a surgery that would get me a D when I was a student. I don't believe in doing anything that's D level work. So if you really want your cuff fixed, you need to find somebody else. Okay, the rest of it is just junk, but I can show you what that junk looks like. Okay, so this is his MRI. So on the MRI, it is really hard to point. Can I point from backwards? Sort of. Only for one side of the room. So he has a medium size or medium amount of retraction. So if you look at the top of the humeral head, you can see the tip of the tendon right there. Everything to the outside of that is torn. This is what we see inside the shoulder. So to the left is biceps tenosynovitis and tendinosis. It's a biceps that doesn't look perfect, but that's pretty normal for age. That isn't really something that bothers him all that much. The circumferential degenerative tearing of the labrum, he's either Drew Brees from 1998, or he's just a guy that's 65 years old, that's a firefighter and has lived life. This looks pretty normal for somebody who's 65 years of age. So his cartilage doesn't look perfect. So that's the kind of beigeish, shiny stuff. And that little bit of fraying on the labrum, which doesn't look all that bad, is what they call circumferential degenerative tearing. This is looking at his rotator cuff. So on the picture on the left, you see the infraspinatus actually looks okay. He's got a little bit of cartilage where infraspinatus looks okay. And then we can see more of the tear when we look a little bit further forward. That white band on the top is the edge of the tear. And that pink stuff that looks, I don't even know what it looks like, kind of like a sea anemone. It's not a sea anemone. One time I did tell a patient he had a sea anemone in his shoulder, and he came back and talked about how he got a sea anemone taken out, like he literally had one in there. It's like, no, you really didn't. That was just synovium, so be careful what you tell patients. But that's the edge of the tear, and this is a medium-sized tear that's kind of retracted into that synovium. So what we do is we repair it, and actually the patient did pretty well. He understands he's got a little bit of arthritis, but we put anchors in, and he does fine because that's entirely repairable. Okay, next case, a little bit younger. How many of you guys see people under the age of 30 that go to Tahoe? Hopefully most of you. Okay, so Tahoe is a wonderful place. We put 4 feet of snow in it, then made it hot and cold and hot and cold and hot and cold for the last 3 weeks. And then we said, go skiing over Christmas. So everybody goes and tries out their new snowboard over Christmas and then comes and sees us, which is kind of awesome. So this is a 25-year-old male. This is second shoulder dislocation. His first time was skiing. Second time was just reaching forward. He's now 8 weeks out. He feels better, but he wants to have his MRI interpreted. His motion is fine. He's got no pain because this is how instability patients present, right? They're fine until they dislocate, and then they're fine, which is why they decide not to have surgery. Every time we sign them up for surgery, they're like, whoa, wait a second. I didn't just dislocate. I don't need this fixed, right? I'm like, okay, I'll see you in 6 years. So full range of motion, positive apprehension and relocation tests. So he feels a little bit nervous when he comes out like this. You push him back on the shoulder, he feels better. Normal strength. Okay, so on his MRI findings, non-displaced tear of the anterior inferior labrum. There is also irregularity of the anterior superior labrum, which may represent additional tearing and a possible small paralabral cyst. Anytime a radiologist says possible, ignore it. Okay, if it's possible, they squinted in one plane and maybe wanted to say that they had a paralabral cyst. If it's so small that the radiologist can't see it with something that can pick up sub-millimeter things on imaging, I'm not going to find it at surgery. You're not going to find it in physical therapy. You're certainly not going to be able to press on it. So if it's possible, it's totally fine. Okay, we're not in the realm of being able to fix possible things. Also, cysts are fine. These are not the cysts. We're not getting a brain MRI, right? If there's a cyst in the brain, there's a worm in there and it's dangerous. If there's a cyst in the shoulder, it means a tiny bit of fluid has leaked in the back. It's fine. And mild subacromial subdeltoid bursal fluid. So he's got a slight bit of inflammation. And unchanged low-grade partial tearing of the infraspinatus without evidence of a full-thickness rotator cuff tear or fatty infiltration. I can almost guarantee you that the without is missed by the patient and they see the word full-thickness tear. But low-grade partial tearing in an area like the infraspinatus where you cannot actually tear it means that there is nothing that I'm going to be able to see at the time of surgery. And there is nothing that's clinically relevant. So anytime it says low-grade, you can tell a patient you're safe to move on from this. Okay, so what is his diagnosis with all that? Dangerously close to calling on Coleman here. What? Yeah, he's got a shoulder dislocation. So when we described shoulder dislocations, Dr. Bankart described an anterior inferior labral tear as the essential lesion of an unstable shoulder because he saw it in every single patient. So this sounds like something that's scary, a non-displaced tear of the anterior inferior labrum. What I tell patients before they go get that MRI is this is what it's going to show. You're going to have a tear of the anterior inferior labrum. It may extend a little bit up the top, so it'll say anterior superior labral tear. We don't worry about that. It may show a small bony defect in the back called the Hill-Sachs lesion after Dr. Hill and Dr. Sachs. Those are expected findings. The reason I get an MRI is because I'm looking for some sort of capsular disruption called a Hegel lesion that will change my approach to operating on you because then I'm going to make an incision versus fixing this arthroscopically, and I'm trying to quantify the amount of bone loss. So that way I try to prepare the patient for, your MRI is not going to look normal because you messed up your shoulder. You dislocated it when you went skiing. That's not my fault. That's your fault. Don't go skiing. But these are things that we expect to find, and the only reason I'm really getting an MRI on this patient is to plan my surgical approach and what I'm going to do for them. So this is what his MRI shows. So if you look at the top front of the shoulder on the axial cut, rotator cuff looks fine. I'm just going to walk and point on each side. He's got this little tiny white line there. That's his anterior labral tear right there. So not big, but it's definitely there. So you can see it right here. Definitely had coffee this morning, but that little labral there is there. And this is what we see at the time of surgery. We see this labrum there, and then it disappears across the front because it kind of scars in a little bit medially. So this is... No, it's not working. So this is your glenoid here. This is your labrum, and it kind of disappears right around the back. Is this going to work? So then what we do is we fix it, and he goes on to look like this. It looks totally fine. Okay, so next one. Almost last one, I think. Oh, yeah. So 67-year-old female, 4 years of shoulder pain, increased pain with overhead activity at night, some pain at rest, and she can no longer paint. She brings in her painting. She's actually a pretty good painting. I find like I can't play music or can't paint. Sometimes it's worth asking them how good they are because sometimes they're really, really talented, and sometimes you're like, it's okay if you don't paint. Tried PT. Sorry, guys, it didn't work. Forward flexion, pretty good, 145. The average person over the age of 70 gets to 150. So one thing to think about is we don't all raise our shoulders up as we get older, and that's okay. Strength, little bit limited, positive Neers, positive Hawkins. Okay, this is long. And this person came in with this thing highlighted, annotated. It looked like she had lived with this thing. Okay, so partial thickness, articular-sided tear, the supraspinatus on background of tendinosis. It's good for the painter in her because the background suggests some sepia tones in it. It's kind of nice. I haven't given this talk before. I'm kind of winging it. I'm glad Coleman laughed. Partial thickness tear of the subscap. That's important, maybe. Background of tendinosis. Supraspinatus, infraspinatus, subscapularis, and teres minor are intact. Okay, well, that makes no sense because they just said it was articular-sided tear. Severe diffuse degenerative labral tearing on limited non-arthrogram sequences. Okay, but no cyst, thank God. Mild medial subluxation of the extraarticular bicep, so the biceps is subluxing a little bit. Severe joint space narrowing and up to full thickness chondral loss with diffuse subchondral cystic change and edema through a glenohumeral joint. And small joint effusion, degenerative synovitis, no intra-articular bodies, remaining muscles are normal in bulk. Okay. So what's her diagnosis? Are you sure? How many of you are 100% sure her primary diagnosis is arthritis? One person. Well, why did you get an MRI if you thought her diagnosis was arthritis? So this is, yeah, well, it made things easier. So what does ChatGPT say about this? Remember, this is a learning model, so it gets better. It also looks at what your computer looks at. So I'm pretty sure it started to learn after I had done these searches for about 4 hours because it started getting better and better. So The most significant findings in this MRI are rotator cuff pathology. It says, despite these tears, the rotator cuff muscles themselves are intact with no atrophy. Great. Severe glenohumeral degeneration, so it picks that up, and labral degeneration. So it's not, ChatGPT is not very good. So all of you that thought or said arthritis, or the 1% raised their hand, you're doing better than the multi-billion-dollar computer. Key clinical implications. So I said, like, basically, what do I do about this? It says the combination of rotator cuff tears, severe arthritis, and labral degeneration indicates significant structural damage and a complex pathology. Those words mean nothing. So treatment planning should focus both on the rotator cuff and underlying arthritis. The most urgent finding, urgent debatable, she's had 4 years of pain, but influencing treatment decisions is the severe glenohumeral joint degeneration. So it actually got it right. So yay, ChatGPT. But again, if I'm a patient, I don't think I get to that part, and the urgent thing is going to scare the crap out of me. Like, I'm in the office the next day. Now, the MRI for this was about, well, if it was us, $7,000. If it was at Simon Med, it was $4,500. But the X-ray cost universally is $110. So I could have saved a lot of money by just getting the X-ray and telling her she had arthritis. And with advanced arthritis, once you don't see any joint, physical therapy may make the patient feel better, but it's not going to actually move the needle that much. So if you want surgery, we should probably consider doing some sort of shoulder replacement. Now, the caveat to that is us knowing that the rotator cuff is in poor shape may help us plan a little bit in terms of what shoulder surgery to do, but I'm also going to figure that out once I make an incision. But we do use an MRI a little bit to look at rotator cuff muscle quality. All right, thank you. That's a picture of Dr. Davies. All right, so we have like 20 minutes. I'm happy to answer questions on shoulder MRI, shoulders, or anything to counteract what Dr. Luke told you about PRP, because I'm kind of a cynical old person. Yeah.
So in this case, you would have initially gotten an X-ray, we would have sent them probably to you, and then you would have gotten an MRI anyways if you were going to do a shoulder replacement?
So technically, this was how this conversation would go. So let's say you sent me this patient with limited range of motion, hadn't tried anything, and they showed up. I would get X-rays, and I would say, are you interested in surgery for this? And if they said no, I would say there's no need to get any further imaging. You have shoulder arthritis. Here are the 4 things we can try. We can do watchful waiting. Arthritis is a cyclical waxing and waning. You might just get better in 6 to 8 weeks, just if we leave it alone and give yourself a little bit of rest. We can do anti-inflammatories, which is either pills or an injection into your glenohumeral joint. We know both of them are effective. The injection into your glenohumeral joint is a little bit better. We can do physical therapy. With this amount of joint space narrowing, the likelihood that you make a meaningful difference is 0 or very low. I try not to say 0, but you may feel better because you've done it, and they may be very good at teaching you how to be more functional within that same window of range of motion and more comfortable because it. Or we can talk about surgery. And if you're interested in surgery, depending on what her exam is like, I may get an MRI. I would say I get an MRI on probably 20% of the patients that are going on to shoulder replacement. It's not necessary because I base whether or not I'm going to do an anatomic or a reverse more on their function and what their cuff looks like at the time of surgery. And all of them have been forewarned, even if they want the anatomic and not the reversal, that most now in the US are reverses. They work just fine, and it's not a salvage if we're doing it for arthritis.
So you go in just assuming I'll figure out if they don't have any like rotator cuff pathology signs in the exam, you'll just figure out what it looks like when you go in drop.
More or less, yeah. Now, realistically, your exam is not sensitive or specific in the setting of arthritis to pick up rotator cuff, but what it is good at is range of motion. So if she's limited down here, so below 100 degrees, and it's been like that for a while, I'm going to do a reverse because her cuff isn't going to get her back up like this. And there's been some good studies in the last couple of years to support that. If I'm really not sure, then I will get an MRI. But ultimately, I still think the problem with an MRI is it always shows partial tearing. If the MRI shows any high riding head, or sorry, X-ray shows a high riding head, or they're really functionally low demand, they're going to get a reverse anyway. Yes, sir.
I'm assuming that part of that conversation is how long rehab is going to be. If they get a shoulder replacement.
Yes.
Because, if somebody's saying, well, do I want to be 6 months? I guess that would be better.
So, I think one of the tricky things is we talk about anything with arthritis, we want to delay joint replacement as long as possible. But the reality, as soon as I initiate treatment, I've delayed treatment. I can say, I need you to walk 500 miles before I do your shoulder replacement. Like, great, I've delayed treatment. It's a success. I've delayed the treatment for shoulder replacement. It works as effective as PRP in the shoulder for delaying treatment. Just kidding, Dr. Luke. If they want to do physical, if they're committed to doing surgery, it's usually not a barrier in terms of like, I'm ready to commit. What I tell patients, the rehab for a shoulder replacement is going to be 6 weeks in a sling where they're very limited and their sleep is horrible. Another 6 weeks where they're working on range of motion, their sleep is bad, but they're not doing strengthening, and 3 months of strengthening where their life is pretty normal and they're kind of catching back up to their age-related cohort. So it's 3 months that they really need to commit. Now, the reality is most patients, if they're not ready for surgery, that's the dividing line. As soon as you say the word sling, you can see in their face, they're not interested, they're not ready. I say, great, let's talk about the non-operative options, because the treatment for shoulder arthritis is going to be the same now as it is going to be for 3 months from now. And then the weird caveat is oftentimes patients are like, great, I want a shoulder replacement in a year because I'm just not ready, but I want to start thinking about it, and that's totally fine.
What seemed like the olden days, these young patients who dislocate, we have them in a sling longer. Now we've got young patients coming out of the slings faster, going back faster. Second time, they have the labrum repair. Seems like there's a lot of people who do okay with a little labrum tear. Is it, when they have that surgery, it seems to work, is it because they're held longer and scarred? Or should we be back to holding these kids longer and letting them tighten up a little bit?
So it's a good question. It'd be great if we had answered that. We have. Not us, but it's been answered. So the nice thing about shoulder dislocations are lots of people dislocate their shoulders, and they're a captured population. So we have very good evidence that length of time in sling doesn't predict recurrence rate. So they've looked at length of time in sling. So as needed, 2 weeks, and 6 weeks. And they've looked at all the different combinations. As needed versus 2 versus 6. The recurrence rate is the same. Your return to play is slower, and it's based on the time out of the sling, which kind of makes sense, right? If you're in a sling for 10 days, you're probably not going to be ready to play sports as quickly as the person who's in a sling for 2 days. Now, you may ask, what if they put them in a fancy sling and put them in a gunslinger? Because there was a study out of Japan in the early 2000s by Dr. Itoi, who said, put people in a sling, in the gunslinger sling, so you're kind of out like this, and he got an MRI. And he showed that the labrum was a little bit more up on the face. So maybe the recurrence rate would be lower. And he did a randomized control trial, and sure enough, if you put people in a sling and a gunslinger, the recurrence rate was a little bit lower. And it was really nice, and it has not been able to be replicated. So part of it is, have you guys seen people in a gunslinger sling? They're out like this. You run into everything. You are now 7 feet wide, and it's almost impossible to get around with your daily life. So we're probably not as compliant as an original captured population. Hawthorne effect. Once you're in a study, you're good about doing it. Most of my patients, when they have dislocations, I say, or all my patients, I say, sling is needed. As you start feeling more comfortable, come out of the sling, start working on range of motion. If you are playing a sport that we need to get you back quickly, there's a different pathway, which is PT right away, get your strength back, brace you if we can for that sport. If not, good luck. And then if you are a recreational athlete, I say it's going to be 6 to 8 weeks before you figure out whether or not you are going to continue to feel unstable. Most patients, age is the most important factor because the younger we are, the dumber the things that we do. So if I have a 30-year-old first-time dislocation, I say, hey, there's a 60-70% chance you don't ever need to see me back. You just do physical therapy and you'll be fine. But that second dislocation is really important. So once you have that second dislocation, your likelihood of having a third is about 99%. And the more dislocations you have, the more you start beating up your shoulder. So I tell patients, unless there's a time-specific reason for your first-time dislocation. So I just finished football season. SI's in the Northern California Championship tonight. If one of those players gets injured, he's going off to college, I will fix him soon so he's ready for college. If it's like, I'm 20, I dislocated my shoulder, I'm an eye banker. I guess he's a little young for eye banking. I'm thinking about being an eye banker. There's no real rush. I'm really good on my club intramural pickleball team. We can try rehab. Success for rehab for me is they have a negative apprehension and relocation. They're back to doing the things that they want to do. And they're kind of up here, not like, I'm fine as long as I don't move my arm. Yes.
I'm a primary care doctor, and I usually approach like MRIs, like they should be ordered by the orthopedic or sports doctor usually, but it pairs up with the referral. Are there any kinds of new things that you, as a PCP, should have ordered MRI beforehand? What are the things that?
Sure, I think that's a great question. So when should a primary care physician or provider get an MRI? I think if you have a high suspicion that they have something surgical and you're expediting their care. So for shoulder, if they come in with what seems an awful lot like a full thickness rotator cuff tear, they're a little bit more high demand. Sometime in the next 5 years, you think that they may benefit from surgery. I think it's totally reasonable to get an MRI. For a young person who's had their second or third shoulder dislocation, my conversation with them is going to be, you don't have an MRI? Go get an MRI and I'll see you back afterwards and we'll discuss treatment options. Can we discuss them now? I was like, I need the MRI to tell you, are we going to make a big incision or little tiny poke holes? So go get the MRI. So I think those are reasonable. I think in the knee, since I have a captive audience, if you think that there's a ligament injury, just get the MRI. Because not necessarily delayed a treatment, but if they have they're an athlete, acute mechanism and a swollen knee, I'm going to do an exam and get an MRI. So that is when it is, I think, totally justified. I don't see insurance pushing back on that. And that's going to guide surgical management for a majority of those patients. If they have an ACL tear, what I'm really looking for that MRI is not the ACL tear. I'm looking, what do I have to tell them about weight-bearing status if I'm fixing meniscus or cartilage?
Do you share your thoughts on therapy?
Yeah, I think 99%, what? I have 10 minutes? Okay, because that was like sunshine hands. Okay, good, okay. So I think 99% of what Dr. Luke said was correct. It is safe. Every single study shows it's safe. Its efficacy is very variable, just like Dr. Luke said. And the problem is we cannot predict who's going to bring more platelets to the party. Until we can do that, I'm very judicious on what I say. The evidence, now Dr. Luke can correct me if I'm wrong, evidence, not anecdotal experience. Evidence suggests advanced arthritis does not do as well as younger patients. Again, remember, the thing with PRP is younger things tend to do better. So younger patients, more isolated cartilage tends to do better than older patients. Rotator cuff, there was just a study in AJSM that looked at tendinopathies, and they looked at, and their conclusion was PRP works better than steroids at 1 year for a tendinopathy. The difference in this wonderful randomized control trial was a pain score of 2.3 versus 1.6 at 1 year. All other differences are negative. Now, if I have an insurance company paying for that, absolutely. But if I have like Cam paying for that, she's an athletic trainer. She doesn't make anything. You know, athletic trainers are like, I want to work really, really hard and not get paid. How do I sign up? So what is the difference between a pain score of 1 and 2 a year out? Is that worth $1,500? Well, I have to leave that up to the patient. I say, look, it's safe. Is it effective? That's up to you. So the data is pretty convincing. You get a small bump over steroids for something like that. For lateral epicondylitis, 100% it seems to work, and we don't know why. And there was another study in AJSM this month that looked at leukocyte-rich versus leukocyte-poor. Didn't make a difference with it when you looked at the individual studies and pooled studies. So it probably matters a lot less than we think. Dr. Luke is both right and wrong. Like, we need more information about this. It's been around forever. This has been around since the 70s. It's not new. It's not exciting. The fact that we don't know much about it is because insurance doesn't cover it, and we tend not to be doing the good science that Dr. Luke is starting to do now. That's really like, why does it work? What are the mechanisms behind it working? And the stuff he's doing with Dr. Villeda is going to be really important, because even in the last couple of years, we figured out, not surprisingly, more platelets better than fewer platelets, right? So it's really, really important, because that can help us figure out who's actually going to benefit from this. Okay. Oh, sorry. Last question.
Yeah, so I do workers' comp. Do you have any pearls in the sense of trying to talk to a patient saying, I expect this on everyone your age, especially because a lot of my patients tend to have my job did this, therefore everything is.
Yeah, so absolutely. So I think it's really tough. David Ring, who's a nerdy hand surgeon, does a lot of work on the thoughts around mechanistic injuries, because he sees a lot as a hand surgeon. And he's got some great papers that I think that I will point out to patients that will be like, absolutely, it was this that caused it. And he has really good framework on how to describe to patients that you may think your arthritis is caused by this, but this is a normal behavioral response. And this is normal findings for age. And the reality, though, is we know that workers' comp is an independent risk factor for things not doing as well. And I'm really blunt with those patients. I was like, because you're workers' comp, you're not going to do as well. And they're like, well, what do you mean? I'm like, you're just not. Prove me otherwise. And then I'll be the person who proves it. And at least you sort of fill in somewhere in the middle. I think giving them the blunt information that we expect a little bit less, that there is a weird system that we're basically going to say, if you do worse, you're going to somehow do better in life, but really you're not. And I think especially more for the manual laborers, reminding them that if you get all the way better, you can go back to doing the thing you're actually good at, because otherwise you're going to be retrained or get less money than you think you're actually going to get, is really important for them. Because I have somebody recently who had large cuff tear. We went through this whole thing. I was like, realistically, if you don't go back to work at 55 years old, you are retrainable at a job that's half your salary right now. He's like, oh, yeah. And your injury settlement's going to be pretty darn low. He's like, yeah, right. Oh, so I should just go back to work. Hey, you might just go back to work. But you have to just spell it out to them. Just like telling a smoker, smoking's bad for you. You probably knew this, but I'm just going to be blunt about it. So. Okay, you have a 5-minute break now, sorry. And then I'm going to be sitting here next to Dr. Davies. Thank you.